So how to control this vector-borne diseases? So the first thing for any disease as it is definitely the case management. Okay, the case management. So how will be the case management be done? So first thing is early diagnosis and prompt treatment. Okay, early diagnosis and prompt treatment needs to be done, and timely referral. Okay, so a referral chain has to be developed that, okay, if there is a complicated case of falciparum malaria, if there is a risk of developing algid malaria or cerebral malaria, then how will be the referral chain? What will be the symptoms based on which a referral will be done? So case management algorithms and uniform availability of high quality drugs and diagnostics throughout the country. So that is case management. But with vector-borne diseases, case management is not alone sufficient. So suppose this was a respiratory illness. So if it was a respiratory illness, you reduce the cases to sufficient extent and you insert some behavioral change communication measures in the public, you will be able to control the outbreak. But for vector-borne diseases, this third population of vectors is very, very important to address. So unless we are able to tackle the vector population, it is never really possible to reduce the burden of the disease by case management alone. So the second pillar of the National Vector-Borne Disease Control Program is integrated vector management. What we mean by integrated vector management, what are the things that are involved in integrated vector management, that we will gradually we will discuss. Okay. And the third thing, as I was saying, are the supportive interventions. So you have social behavior change communication, you have public-private partnership, you have vaccine. You all know that we have the Japanese encephalitis vaccine. The malaria vaccine is under development, has not yet come. Okay, so training, research, monitoring, and surveillance. Okay, so these are the three broad strategies that are undertaken by the National Vector-Borne Disease Control Program. Okay. Now going ahead, so how will these be done? So definitely for early diagnosis of cases and their prompt management, what you need is surveillance. So what kind of surveillance? What kind of surveillance is required? So surveillance that is usually done here is active surveillance. So what active surveillance is done? Active surveillance means where the healthcare worker will go into the community to look for cases. Okay, so the multi-purpose worker who is there at the level of the primary healthcare, you already know from your knowledge of healthcare system. So the multi-purpose worker or the ASHA worker is given this task of visiting the houses by house to house visits and looking for fever cases once in every 14 days. Okay, so the ASHA worker will go from house to house and will look for cases once in every 14 days. So that is known as active surveillance, active fever surveillance that they will do. And the moment they find that, okay, there is a house where there is a person who is having fever along with this, that is fitting the case definition for either malaria or for dengue or for, what they will do is, so for malaria, they will do a finger prick and they will do they will develop the thick smear on the thin smear. And then they will try to diagnose if there are malaria parasites by microscopy. Okay, so this is active surveillance that the ASHA worker will go by going from house to house. Next, what is passive surveillance? Passive surveillance is when the patient will come to us. So the patient will come to us in the OPD, and if that patient is coming with fever during the high transmission seasons of the vector-borne diseases, then that patient will definitely be screened for malaria, dengue, filaria, and according to what is locally prevalent. Okay, so surveillance, active surveillance, passive surveillance, and sentinel surveillance is done for these vector-borne diseases. Also, epidemic preparedness and rapid response. So if there is outbreak at any area, then what interventions will be taken? So for example, suppose there is a case of, say kala-azar reported in one village. Then what will happen? That entire village will have to be covered by indoor residual sprayings, fogging. Cases have to be screened through that entire village. So this is a epidemic preparedness. The moment you have one case, you put in all your efforts in order to ensure that it does not lead to an epidemic. There is no second generation of cases. Okay, the surveillance is once in 14 days also to ensure that there is no second generation of cases. If I'm able to detect one case, then from that case, the mosquito will have to take a blood meal. Then the mosquito, then the plasmodium will have to undergo certain changes, developmental changes, multiplication in the body of the mosquito. Then again, the mosquito will have to bite another individual, and then only that individual will get infected. So that time that will take more than 14 days. So if we are having a coverage of all the households every 14 days, then it will ensure that there is no second generation of cases. I'm able to detect cases whenever the outbreak is happened, and I'm able to prevent the second generation of cases developing from the first generation of cases. Okay. Next comes the concept of integrated vector management. So integrated vector management, I will discuss in detail. I'm not going into its details right now. And also the supportive interventions that we have already spoken about. So let us begin our discussion with malaria as the point in case. So we have the National Framework for Malaria Elimination that is in effect from 2016 to 2030. From 2016 to 2030, we are having the National Framework for Malaria Elimination, where we are planning that, okay, by 2030, we will have had nationwide elimination of malaria. Okay, malaria will cease to be a public health problem in our country by 2030. So for that, we are classifying all of our districts and states into 4 categories. Okay, a category 3, a category 2, a category 1, and a category 0. Okay. And this category classification that we are doing it on the basis of annual parasite incidence. So what is annual parasite incidence? Annual parasite incidence is the number of cases, number of new cases of malaria divided by the total number of population under surveillance multiplied by 1,000. Okay. So that is the annual parasite incidence. Okay. So based on this, we are classifying our districts into category 0, category 1, category 2, and category 3. Okay. So as you can understand that the category 3, which is the first stage, which is known as the intensified control phase. So what is intensified control phase? Intensified control phase is the states or UTs with API greater than 1 across the state or the union territory. Okay, so all of the states which are reporting annual parasite incidence of more than 1 per 1,000 population across the state or union territory, then they are in the intensified control phase. So what is intensified control? So that means here the transmission is still high and we have to first reduce the level of transmission. Okay, so these are the states in the intensified control phase, and 10 states or union territories are in this intensified control stage, mostly the northeastern states. Okay, next from category 3, states will transition into the category 2 stage. Okay, which is also known as the pre-elimination stage. So what is the pre-elimination stage? At this stage, the overall state API has fallen less than 1. As I was saying, we first achieve the statewide thing, but some districts are having an API of more than 1. Okay, so we have eliminated at the level of the state, but at the level of the districts, the elimination is still pending. Okay, so there are 11 states and union territories which are in this state. Okay, where the API is less than 1 for the state, but some of the districts are having it more than 1, including West Bengal. Okay, so if you look at West Bengal, all of the districts are having an API less than 1 except for Kolkata. Kolkata is having an API of more than 1. Okay, so once Kolkata's API also comes less than 1, then West Bengal will also transition from pre-elimination to elimination phase. So what is the elimination phase? Elimination phase is where the API of the entire state is less than 1. Okay, so the entire state, including all its individual districts, the API is less than 1. And there are 15 states of this country, mostly states in the northwest of India, where it is cold and also dry. So those are the states where they are in the elimination phase. Okay, so elimination is API less than 1.
Sir,
Yes.
Sir, if it is cold and dry, then why isn't the API absolutely zero?
Very few parts of India are having cold and dry across the year. Okay, India is a tropical country, isn't it? So these are states which will have some seasonal transmission. Okay.
Yes, sir.
Not perennial transmission, but some seasonal transmission will be there.
Okay,
Okay.
sir.
And then they will move from category 1 to category 0. So category 0 is where there are zero indigenous cases of malaria. So when there are zero indigenous cases of malaria, so that means even if a single case is detected, it has to be established that this is not an indigenous case. This is a case that has been migrating from outside. Okay. So the target is that by 2030, all of the states, they will achieve category 0. Okay. As of now, we are gradually moving from category 3 to 1 to 1, 3 from 2 to 1 and then to 0. Right? This part is clear to everyone.